How bad is my background noise?
Yeah, you can start. We are live.
Good evening, everyone. Welcome once again to another webinar from the All India Ophthalmology Association Scientific Committee. It's my privilege to welcome all the speakers in this group, and especially the moderator for this entire session, Dr. Manjeshri Bhatte. For those of you who probably know her, Dr. Bhatte is a senior uh, pediatric ophthalmologist and neuro-ophthalmologist practicing at LV Prasad Eye Institute in Hyderabad. She has trained both in India and also in Australia, where she also practiced before she joined LV Prasad Eye Institute in Hyderabad. So it's my pleasure to invite her. We also have our presenter, Dr. Arif Khan, who is going to be the chair for this session. And in addition to him, we have 6 very, very interesting and challenging cases, which will be presented by expert speakers. And these cases will be discussed by pediatric ophthalmologists who are specialists in their own field. So with that, I would like to hand over to Dr. Manju. Manju, at the onset, I would like to thank you for putting together this excellent webinar. I'm sure that this webinar is going to be extremely useful, not only for the pediatric ophthalmologists, but also to general ophthalmologists, residents, and fellows, because there will be a lot of learning and a lot of content that they can look at. So very quickly, that it's not just the webinar that we're doing today, but it will also be live streamed on Facebook as well as on YouTube, and everybody can access it later. So thank you everyone once again for joining in, and over to you, Manju.
Thank you very much, Somshila. I'd just like to share my little presentation that I've made. Okay, is my screen visible?
Yes, doctor.
Okay, thank you very much. So I welcome everyone to another webinar on pediatric ophthalmology, this time by the All India Scientific Committee. And this is going to be a special webinar because we've not just included a variety of cases of pediatric ophthalmology, but we've also included some aspects of ocular genetics. And to chair our webinar, we are honored to have Dr. Arif Khan. He is a very well-known pediatric ophthalmologist and ocular genetics around the world. So I'll just begin by a few slides that I've got. So the first is to introduce Dr. Arif Khan, who is the interim chair of ophthalmology and the section head of pediatric and neuro-ophthalmology at Cleveland Clinic, Abu Dhabi in UAE, and also the professor of ophthalmology at Cleveland Clinic, Lerner College of Medicine, USA. Previously, till 2015, he was a senior academic consultant at the King Khalid Eye Specialist Hospital and the senior scientist at the King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. And he was practicing in New York before moving to the Gulf for a number of years. Dr. Arif Khan's clinical and research interests are genetic eye diseases, as we all know, and pediatric ophthalmology and strabismus. And he's a internationally well-renowned pediatric ophthalmologist. And we're really honored to have you and join in and give us our guest keynote lecture as well today. So thank you very much, Dr. Arif Khan. With this, I'll move on to introducing our other co-chair, who is Dr. Namrata Sharma, and she is the chair of the Scientific Committee of All India Ophthalmology Society, who organizes these webinars for the wide learning of all ophthalmologists across India and beyond. And my co-moderator, Dr. Somshila Murthy, she is a senior she is the director actually at Shantilal Sanghvi Eye Institute and was formerly the head of cornea at LV Prasad Eye Institute at Hyderabad. She is a member of the Scientific Committee of All India Ophthalmology Society and another very well-known cornea specialist. And thank you, Somshila, for coordinating and co-moderating and organizing this webinar as well. we'll move on to our presenters and discussants. So we've tried to make this as a pan-India webinar. So we've got to begin the cornea presenter, Dr. Neha Jain, who is from Ambala, and the discussant, Dr. Murlidhar Ramappa, who's my colleague at LV Prasad, Hyderabad. For the glaucoma, we've got a nice fancy title, and we've got Dr. Rashmi Krishnamurthy from LV Prasad and Dr. Sushmita Kaushik from PGI Chandigarh. After these two cases, we will have Dr. Arif Khan's keynote lecture, which will be on iris science, not to miss. And followed by that, we'll go on to the lens abnormalities. So we have Abhinaya Valiappam from Chennai, and I'll be the discussant for that, followed by a retina presentation and discussion by Dr. Deepika, who is from NN in Bangalore, and Dr. Parveen Sen Ken from Chandigarh. And we will wrap up with an optic neuropathy case by Dr. Jenil Sheth, who is from SSCI in Mumbai, and with Dr. Swati Fuljale as the discussant, who is from AIMS RP Center, New Delhi. So thank you everyone for joining in and for your wonderful cases, and I'm looking forward to having this webinar. So I'll stop sharing now, and I'll invite Neha, who is our first presenter, to start sharing her screen, please. So we've tried to time it in such a way that we have about 6 minutes or so for the case and then some time for the discussion.
Good evening. Are my slides visible?
Yes, Neha, you can go ahead.
So good evening, I'm Dr. Neha. Thank you, AIOSSC, for this wonderful opportunity to present my cases here. So I'll be presenting certain cases of pediatric herpetic ocular infections. Is my slides moving?
No.
I just stop and on. Sorry. So the first case is of a 12-year-old girl who presented with redness, watering, photophobia, mild discharge, and blurred vision in right eye for 1 month. She had a history of fever prior to the onset of ocular symptoms and similar complaint in the right eye 4 years back. She did not have any complaints in the left eye, and there was no significant systemic history. This was the photograph on presentation, where on staining we can see there were 2 dendritic ulcers very clearly demarcated in the right eye. So we treated her on the lines of a right eye HSV dendritic keratitis with topical ganciclovir homide eye drop. Then on follow-up, the lesion had resolved. So we continued her on a prophylactic dose of ganciclovir BD owing to the frequent recurrences she was having. After which she resolved, but then the recurrence was noted, and we again had to step up the topical antiviral to 5 times a day after 3 months. Subsequently, the lesion again had resolved, but the mild edema was persisting. So after 1.5 months, we had to again start her on topical steroids in order to resolve the edema. Eventually, the episode had resolved and a corneal scar was seen. She was maintained on a topical ganciclovir BD dosage, but there was no recurrence noted over a period of 6 months. So we had discontinued all the topical antivirals. We can see the corneal scar which was present in this case. But after we had actually discontinued everything, she again had a recurrence in a 1 month span. This time it was not a dendritic lesion, but a stromal edema, and the visual acuity had also dropped down to 4/60. The fluorescence stain was negative, and on the OCT also we can see that she had a central edema. So this time we had to add topical steroids along with the antiviral cover, which subsequently resolved, and the visual acuity also improved to 6/18. My second case is of a 15-year-old girl who presented with blurred vision, redness, and watering in right eye for 4 to 5 days. There were no similar complaints in this eye or the other eye earlier, and this episode was also after a 3-4 days history of fever. She had HSV, she had a central stromal edema, which could be seen on slit lamp also and OCT as well, and presented with visual acuity of hand movement. We had treated her on the lines of right eye HSV endothelitis. So we had started on oral valcyclovir full coverage of 500 milligrams 3 times a day, along with Predfort 1 hourly and homide eye drop. Within a span of 1 week, the stromal edema had decreased, and subsequently the vision also improved from hand movement to 6/36. So the tablet was reduced to an OD dosage of prophylactic dosage, and the topical prednisolone was tapered off. She eventually started resolving by day 40, and only the prophylactic dosage of the medication was carried forward. We had to stop the oral tablet at this visit because she was not able to tolerate it. Within a span of 10 days, she had a recurrence, so we had to again step up the antivirals and add tablet Balsivir again to in the TDS dose. She responded again beautifully with the subsequent mild scarring, and the visual acuity improved to 6 by 12 parts. The third case is of a 10-year-old girl who presented with redness, watering, and discharge in both eyes for 2 days, with no similar complaints in past, but a history of aphthous ulcers since 1 week. On slit lamp examination, we saw membranes in the upper and lower palpebral conjunctiva, and mild staining was also seen on the cornea. So this was more looking like an adenoviral conjunctivitis case. But when we went ahead and examined, she had vesicular lesions all over her lips. So we had to send her to a dermatologist who diagnosed it as a case of primary herpetic gingiva stomatitis with unilateral blepharokeratoconjunctivitis. So we treated her with antivirals along with tablet prednisolone, which was added by the dermatologist. So my takeaway from these cases is that personalized treatment, including the antiviral therapy and ocular rehabilitation, is crucial for improving outcomes and preventing long-term visual impairment in these cases. And it also highlights the need for heightened awareness and understanding of herpetic eye diseases in pediatric population to ensure the optical management and visual results. Thank you so much.
Thank you very much, Neha, for presenting these wonderfully managed cases of pediatric herpetic eye diseases. So I'm going to first ask Dr. Muralidhar for his inputs, whether he does anything differently or he would want to add anything specifically in looking out for these cases or having a high index of suspicion. Sometimes we don't really see obvious dendrites in the cornea. So Muralidhar and Somshila, if you could share your inputs, please.
Yeah, thank you, Dr. Manju, for having me here. And thank you, Neha, for a wonderful, entire spectrum you covered so beautifully. Yeah, herpes, the history is a mainstay, as she rightly, and the clinical manifestation, the constellation of clinical signs. Investigations are only in extreme cases. So we mainly rely on history, and the key characteristic clinical signs actually clinches the diagnosis. And we mostly resort to those systemic, antiviral. They're pretty effective, well tolerated in children. And yeah, so very rarely we use the topical medications. And as she pointed out well, all those lesions in the visual axis do merit, steroids under the cover of acyclovir, and that really help in resolving the, corneal edema or a corneal scarring in the center, because it's so important to keep the visual axis very, very clear during the, neuroplasticity, and also, appropriate, spectacle correction, certain time, amblyopia therapy. Because they're most often, as she showed in a case 3, they can have a recurrent primary blepharokeratoconjunctivitis that is always infective. And also it's been documented in the infancy, nearly 95% of all follicular conjunctivitis, perhaps due to herpes. Until you proved otherwise, so you deem it to consider it as an herpes. And particularly the, history, obstetric history, if the child is, normal vaginal delivery, if mother may not have any active signs or, history of, genital herpes, and that's one of the way, how, neonate acquire infection. Okay. We also, categorize particularly herpetic neonatorum, which is typically manifests in the first 28 days. We have to, based on the clinical signs, we have to segregate whether it is a SEM, skin, eye, mouth disease, that is a very regional variant, or a systemic, or a neural variant. In a systemic, you have all multi, liver, everything is involved. So that carries a higher mortality, whereas a neural variant, carries, a lot of morbidity because of a central nervous system insult. And all these cases have to be treated in conjunction with the pediatrician. Sometimes we also resort to parental acyclovir. So that's a treatment of choice, particularly when we deal with herpetic neonatorum. Thank you, Dr. Manju.
Thank you. These are very useful tips that you've shared with us. Dr. Arif Khan, is there any comment from you?
Yeah, thank you so much, Dr. Manju, for having me and also for AIOS for having me here. This is a very important topic, and there are just 3 points I'd like to make. I don't know what the practice is in India, but I find that primary care physicians and sometimes even ophthalmologists, when a child comes in with a viral conjunctivitis, which is so common, they give them a low-dose steroid antibiotic because this is marketed by the company. But we actually recently had a case that was given that they didn't get better and they ended up having a dendrite. So when you give these low-dose steroid antibiotic combinations to children who come in with conjunctivitis, you could be making it worse if it's a herpetic. So don't give those drops loosely. Actually, most of those cases, the simple conjunctivitis get better by themselves. You could give them tears, but really, we should avoid giving these low-dose steroids that I unfortunately see happening not uncommonly because it makes the eye less red. The second thing I'd say is that some of these children who get the herpetic keratitis, of course, are prone to reactivations. And it's well documented in adults, and it's well known in children also, that some of them require low-dose acyclovir, indefinitely. And it significantly reduces the risk of recurrence in those children who have this predisposition to recurring. So sometimes we have to manage these patients on low-dose acyclovir indefinitely, especially when they're children and they might not complain as much. If there's a documented recurrence of the epithelial keratitis over and over again, we really should consider giving low-dose acyclovir. It's very safe and it significantly reduces the recurrence. And the third thing I'll say is sometimes these patients get, the herpetic disease is treated, the epithelial disease is treated, but sometimes they get recurrent stromal keratitis. And sometimes they require chronic steroid. I mean, we don't want to do that if we don't have to. But I have patients that, if they they're down to 1 drop per week of steroid. And if they stop it, the stroma starts to get hazy. So we have to watch these patients carefully because even if we treat the infection, sometimes they get this later on stromal keratitis, especially in the very young children. As Dr. Murley was saying, it can be amblyogenic. So we have to follow them, and sometimes they require chronic low-dose steroid. It's really a huge topic. We could talk about it for the whole session, but I'll stop talking there. It is very important because it's so common, and this will be encountered by general ophthalmologists for sure. I think the biggest problem is under recognition of the condition.
Thank you. Thank you so much, Dr. Arif Khan. And other important thing, we need to rule out atopy, particularly in children. That could be one of the potential risk factor for a bilateral herpes, particularly. As Dr. Arif well pointed out, they have recurrences, more of infective recurrences. They are very recalcitrant, may not sometimes respond. And I have a children, sometime I keep a weekly 1 single drop prednisolone acetate. So to keep their cornea clear, the moment you stop, as you rightly said, they come with a recurrence. And some of these children's minimum acceptable dose, sometimes I go as low as a 10 milligrams. You can say it is a homeopathic dose in order to keep the virus under control. So sometimes it is indefinitely we may have to consider. So the allergy seems to be, atopy seems to be one of the biggest risk factor for a multiple recurrences that has to be recognized.
Thank you very much.
I just can't resist saying one last really quick thing. The dendrite, of course, is classic for the herpetic disease, but there's one rare genetic disease that comes in with dendrites. This is tyrosinemia type 2.
Yeah.
And they can come in and can look just like herpetic dendrites. And they get these lesions on their palms and digits. I just can't resist mentioning that in the context of this. Thank you.
Yeah. I think, tyrosinemia is one of the differential diagnoses, particularly in South Asia. Palmoplantar hyperkeratosis is one of the, again, hallmark when we examine them. And mainly, milder variant, type 2 and type 3, they are viable. They can present. In addition to they have a tyrosine crystals on a conjunctiva, you may also have a keratinization, something almost reminiscent of a vitamin A deficiency. Great points. So we have to, often we have had such cases, particularly congenital anesthesia, tyrosinemia, vitamin A deficiency have been wrongly, treated in terms of, virus, and they get aggravated. Okay. So it's important to ascertain a root cause in such cases. Thank you.
Thank you. Thank you very much for that great, insightful discussion. And with this great kickstart, we move on to the next presenter. So we have Rashmi Krishnamurthy, and she will be talking on Big Eyes Tell a Story. Over to you, Rashmi.
Good evening, everyone. Can you see my slides?
Yes, we
Manju,
can
you're
see
muted.
that you're audible. Go ahead.
Yeah. Thank you. It's my pleasure to be here today and present. Thanks, Dr. Manju AIOSSC, for giving me this opportunity. So I would like to tell a story about Big Eyes. So yeah, so my first case is a 18 days old baby who was brought to us by parents with whitish discoloration of both the eyes since birth and right eye more than the left. And the baby was prescribed dorzolamide timolol combination by a local eye hospital and referred here. The proband parents married in consanguinity, and none of the siblings or none of the people in the family were affected by any eye disease. So when we did an examination under anesthesia prior to surgery, we noted that there was right eye grade 3 corneal edema and no substria, and left eye had grade 2 corneal edema, and horizontal corneal diameter was 11 in the right eye and 10 millimeters in the left eye, and the intraocular pressure was 27 millimeters mercury in the right eye and 24 millimeters mercury in the left eye. So this was a clear-cut case of primary congenital glaucoma, and we performed a conventional combined trabeculotomy with trabeculectomy. This is a representative video which shows the same surgery. After limbal-based conjunctival dissection, the superficial scleral flap is dissected, and careful and meticulous dissection is important, especially when we reach near the limbus, because that is where our limbal anatomy lies and that is where we identify the Schlemm's canal. So once we demarcate the deep ostium, a radial incision is gradually deepened in the area of Schlemm's canal, and there's ooze of aqueous, and we use Harm's trabeculotome to perform around 120 degrees of trabeculotomy. So once this trabeculotomy is done on either side, the deep ostium is dissected, and we do a superficial superior peripheral iridectomy, and then the apical suture is used to close the scleral flap, and continuous conjunctival closure is done with 80 Vicryl. So coming back to our case, we did examination after 6 months, and the baby was doing well. The pressure in both the eyes was under control, under anesthesia, and HCD was stable. The baby had grade 1 corneal clarity in both the eyes, and in the right eye, the cupping was slightly more when compared to the left eye. We did genetic testing for this baby, and there was a likely pathogenic variant of CYP1B1 in this baby. So the mother was pregnant for the second baby, and unfortunately she expired when there was PIH. So the child was brought by the grandmother at 2 years of age, and the baby was doing well. So we know that conventional trabeculotomy and trabeculectomy works well in these eyes, especially in classical primary congenital glaucoma. It's very important to identify the Schlemm's canal. So it's said that where white meets blue, Schlemm's waits for us, and then there is presence of perforative vessels, and there's a dip between the two zones where we can identify the trabeculotomy. Apart from Harm's trabeculotome, we also has this indigenously developed 360-degree trabeculotomy done with the help of a illuminated microcatheter. So this does well in PCG. But coming to our second case, this is a 2-month-old baby who was brought to us by parents, similar complaints, whitish discoloration of both the eyes since birth, proband parents and paternal grandparents married in consanguinity. So prior to surgery, when we did examination under anesthesia, the corneal haze was grade 4 in both the eyes, and there was presence of ectropy on uvea on oblique illumination. And the HCD was 11 millimeters in the right eye and 12 millimeters in the left eye, and the intraocular pressures were raised in both the eyes. This is a UBM and B scan, which says that there is corneal edema and the retina is attached, which is done pre-operatively. And this is the history of the follow-up visits of this patient. 6 months later, when we saw the patient, the pressures were still high. The patient underwent right eye Ahmed glaucoma valve implant, and the left eye was a severe presentation. So we did limited transcleral cyclophotocoagulation. And again, after 3 months, that is 9 months from the primary surgery, when we did examination under anesthesia, this is the appearance. It is same as how it was at presentation. The cornea is hazy, but there was some peripheral clearing. So this patient underwent inferior optical iridectomy. So because genetic testing was done for this patient, this was positive for CYP1B1. Because after the optical iridectomy, tube excision, the baby had ambulatory vision. No further interventions were done, and limited TACPC was done for the second time. So what's different between the two cases? Case 1 also had a likely pathogenic variant of CYP1B1, and case 2 also had likely pathogenic variant of CYP1B1. But the difference is the location of the mutation, that is in exon 2 and exon 3. So, and the type of variant. So this CYP1B1 gene is a key, CYP1B1 is a key enzyme which is involved in the eye development, particularly in the trabecular meshwork and ciliary body, which regulates the intraocular pressure, and mutations in CYP1B1 impair its function, leading to dysregulated pressure, optic nerve damage, and PCG. It contains the 3 exons and 2 introns. So with this varied presentations, in fact, we did a study to differentiate and analyze various CYP1B1 variants, and we noticed that broadly there were around 17 CYP1B1 variants out of 28 cases that we studied, and broadly when we saw there was 12 in exon 2 and 16 in exon 3. Exon 2 variants were doing relatively, they were more severe at presentation, as well as the prognosis was poor when compared to exon 3. And in fact, preoperative and postoperative characteristics also were the same. The number of repeat surgeries and last follow-up IOP was higher in exon 2 variants when compared to exon 3. And though the complete success was almost similar, qualified success was better in exon 3 variants when compared to exon 2. So from these two cases and from the study that we have done, we have realized that there is PCG exhibits a diverse phenotypes and outcomes necessitating individualized management. While the phenotypic appearance partly hinges in understanding the prognosis, genetic counseling and testing helps in identifying the CYP1B1 mutations, understand the inheritance, and guide for further management. The variants are very important, and personalized treatment strategies are needed in these cases. Thank you.
Thank you, Rashmi, and thank you for that wonderful presentation and your 2 different cases. And I was just wondering, would you have changed your management approach in the second case, knowing that there's a different variant, and now your study is also showing up their prognosis? So I'm going to hand over the discussion to Dr. Sushmita. She's a very experienced pediatric glaucoma surgeon, and then we'll have input from Dr. Arif Khan. So over to you, Sushmita.
Hi, thank you, Rashmi. Thank you, AIOSSC and Dr. Manju, for having me on this very interesting webinar. So, yes, we have also noticed that it's simply not one disease. So first thing is congenital glaucoma is not one disease, and then PCG appears to be not one disease. So it's interesting that you said that it's CU. And the only diversity I noticed from your cases, which is different from ours, is we see more severe disease with the arginine 390H always. And when we see neonatal onset CU and partial aniridia, it's almost always a biallelic arginine 390H for in our cohort. But then this particular variant is a founder mutation which was seen in Pakistan. So I suspect we are the same ethnic group, and they had also what they did. Sarfarazi's group, I think, did genotype phenotype variation correlation, and the arginine 390H was the worst that they had as well. And contrast this to the papers from L.V. Prasad, which we looked up. Actually, the R390H was not very common. And what was common, what was interesting is the G61E, which is actually the one seen in the Saudi Peninsula. And Professor Arif is here, but he called it mild, partial aniridia, very similar looking to our severe iris hypoplasia. But he also noticed the biallelic G61E, which is the most prevalent one in the Middle East. So I think ethnic groups should also would also matter possibly in how the expression of the genotype is, but there is no, as far as I could see from our little observations as well, that we really could not correlate phenotypes with CYP1B1 genotypes or variants, except in our population for the R390H. So and I think Dr. Ken Nischel calls it a CYP1B1 cytopathy. It is characteristically a spindle. What I've noticed is the edema subsides all around, but we are left with a spindle-shaped central opacity. The good thing, if you can call it a good thing about it, is that there's so little iris that if you manage to clear about 2/3 of the cornea, even with that little spindle, many of them don't actually require an optical iridectomy because there's no iris. So inferiorly, these children could possibly see well, but it's a very, very intractable disease. That's true. Dr. Arif, what would be your takes on this?
Yeah, thank you so much. Of course, this is a great topic. I'll just make 3 points. One is that, as was asked about, how does the genotyping help? Actually, the genotyping doesn't tell you anything about how you're going to deal with the patient. You examine the patient, and your care for the patient is completely phenotype driven. So you're not going to use the genotype in any way to determine how you're going to manage the patient in front of you for this condition. That's one thing I'd like to say. The second thing is, I think we have to be careful about our terminology. When we say primary congenital glaucoma, we mean that only the angle is affected and any other structural changes in the eye are a result of increased intraocular pressure in an infant. When you start having ectropion uvei, or you start having a corneal intrinsic keratopathy, that's no longer primary congenital glaucoma.
Yeah.
That's a form of anterior segment dysgenesis. This might seem like a minor thing, but I think we really should try to be precise in our terminology. So biallelic CYP1B1 mutations can cause primary congenital glaucoma or anterior segment dysgenesis. I wouldn't call that phenotype of the keratopathy with the ectropion uvei and partial aniridia. I wouldn't call that primary congenital glaucoma. That's a form of anterior segment dysgenesis. And the third thing I'd like to say is, for sure, unfortunately, there's no clear phenotype-genotype correlation with CYP1B1 mutations. There definitely are trends. And certainly in certain populations, you can have founder mutations. So you see a particular severe phenotype, and you can be pretty certain that what the mutation is because you know your founder population. But I can tell you from personal experience, as was mentioned several times by Dr. Sushmita, the G61E variant, which is common in the Middle East, we see it in homozygosity. We see it causing that severe congenital corneal opacity, ectropion uvea, partial aniridia, severe horrible glaucoma, which, by the way, is a marker for a very difficult disease to deal with. I've seen that in just regular primary congenital glaucoma.
Yes.
I've seen that in juvenile glaucoma. And then I've seen relatives who have the same variant and they don't have glaucoma yet. They get it. They get an adult onset glaucoma. So you can't look at the variant and predict what's going to happen. But when you have a severe phenotype and you know your population and you know the common mutations, you can be pretty sure what it is. So actually, I'll just give one more point, very important point. If you have a family who has severe congenital glaucoma running in the family and they have a newborn and there's no glaucoma in that newborn, the family might feel relieved because everyone else had severe congenital glaucoma that was present at birth, but they're not out of the woods because sometimes those mutations cause a juvenile glaucoma. So they still have to be followed, or even better, genetic testing. This is a great example for genetic testing. You find out what is the mutation in the proband, then you can test the siblings and you know whether or not they have that risk or not. Because just because they're normal as infants doesn't mean they're not going to get the disease, even though it's not the severe disease of the proband. Thank you so much. A great, great topic, great discussion.
That's a
Dr.
great.
Arif, can I ask one question? In two cases, one was a missense mutation and the other was termination. Does that really matter in the phenotype?
I mean, in general, you know,
Okay.
the truncating mutations tend to be more severe, and in general, the missense mutations. But you can't predict from
Sure.
the you just can't. That's my experience for at least for CYP1B1.
Thank you.
There certainly are trends, but you can't predict it. Because there are people who have the severe mutation, which causes the severe congenital ectropia and partial aniridia and the keratopathy, but the brother has the same variant and he doesn't have glaucoma and he's 5 years old.
That's
So,
true. Yeah.
yeah.
Thank you. So that was a great discussion, and I think it's very important, as you said, that if you know the family is relieved that a child does not have glaucoma, it's definitely a very good idea to get a genetic testing, and then you can say now you can be relieved or not. I think after this, the plan was to go ahead with our guest lecture, that is the keynote lecture by Dr. Arif Khan. So I'd invite Dr. Arif Khan to please share his screen. As I've introduced before, Dr. Arif Khan is a very well renowned pediatric ophthalmologist and ocular geneticist, and we are very fortunate to have him share his expertise with us in this webinar. So over to you, Dr. Khan.
Great. Can you see my screen?
Yes, we can.
And you can hear me. Okay.
Thank you.
Well, thanks again, Dr. Manju, really, and thanks for AIOS for having me. It's really a pleasure to be here. Let me just get this bar off of my screen. Where is it? Hide the floating meeting control. There. Okay. So what I thought I would speak about here is something that's not spoken about that often, but I think is important. And basically, iris signs not to miss. You know, we look at the iris, of course, but maybe we don't look at it as carefully as we should. And there are some things that are very key in children who come in with reduced vision, and we have to pay attention to them and look for them because if we don't note them, who's going to note them? Nobody else is going to see them. The other specialists are not. So I would like to share with you a few iris signs that are important not to miss. And the first one is exemplified by this case, a 16-year-old male. He comes in with reduced vision of unclear etiology. That's why he's referred. It's 20/40 in the right, 20/20 in the left. There's no strabismus, there's no APD, there's no significant refractive error. There's some mild disc pallor, but it's really unremarkable. We see that a lot in patients, doesn't mean anything. And the retina is within normal limits. And when we look at his iris, that's where we make the diagnosis. What do we see? We see these mounds. It looks like clay was thrown on the iris. It's a different color from the brown iris. And this is a two-dimensional picture, but if you saw it in three-dimensional, again, it looks like someone took a piece of clay and threw it on, and it's just plopped on there. These, of course, are leash nodules. And you do a VEP on this patient. The VEP is abnormal. This child has optic nerve glioma. It's bilateral. That's why there's no APD. And he has undiagnosed neurofibromatosis. So we just made a genetic diagnosis without doing any genetic testing, just by taking the history, looking at the situation, and looking at the iris. Neurofibromatosis type 1 is so common. I have no doubt that everyone who's listening to this right now has encountered a person with neurofibromatosis, and you don't know that person has neurofibromatosis, and even that person doesn't know he or she has neurofibromatosis, because there's such a variable expressivity. You can have some individuals who have horrible skeletal deformity, they have glaucoma, they have scoliosis, where you have other patients who have mutation in the NF1 gene, but they just have a few leash nodules and maybe some mild optic nerve glioma that's not significantly affecting the vision. They don't even realize they have the condition. It's much easier to pick up leash nodules in a patient with a lightly colored iris. And again, it's not intrinsic to these lesions are not intrinsic to the iris. It's like somebody has taken some clay material and thrown it on. It's very prominent in a lightly colored iris. In a brown colored iris, maybe it's not as easy to see, but still it's quite distinct. Here's a 4-year-old girl, asymptomatic, came for routine exam. The mother has no neurofibromatosis. And sure enough, what do we see on the iris? We see these leash nodules. She's affected. Again, we just made this genetic diagnosis just by looking carefully at the iris. A 26-year-old female referred because of multiple cafe au lait spots, no visual complaints. The primary care provider referred this patient for an eye exam. Well, she's 26 years old, and look at these juicy, plump leash nodules she's had all this time. Nobody knew because nobody looked with the slit lamp. Again, an iris finding not to miss. Leash nodules, especially when a patient comes in with reduced vision of unclear etiology, take a good look at the iris. Now, this sometimes gets confused with leash nodules, but it's different. You can see how it's different. Look how many of them there are, first of all. It's so many. And this is more intrinsic to the iris. It's not like somebody threw some clay on. This, of course, is a different condition. It's not necessarily a sign of disease. It can happen without any associated disease, but sometimes it happens in hyperpigmented states. These, of course, are this iris mammillations, and this child happened to have nevus of Ota on that side. It doesn't mean anything, but it's just a different iris sign. It's not a leash nodule. So the first iris sign not to miss is a leash nodule. Let's move on to the second scenario. It's represented by this girl with nystagmus and low vision. Nobody could understand why she had low vision. The retina looks normal. The optic nerve looks normal. She had neurological workup, including an MRI. And she eventually made her way to the eye clinic. And here she is. Of course, I think you suspect what we're going to do is we're going to look at her iris. But what are we looking for her in her iris? Any child who comes in with nystagmus, unexplained nystagmus, and low vision, or unexplained low vision, we want to look at the iris for iris transillumination defect. And this patient has undiagnosed oculocutaneous albinism. Now, nobody is going to miss a patient like this who comes in with nystagmus and low vision and a fundus that looks like this and an iris that looks like this. Nobody's going to miss that this patient has albinism. Even a lay person, a non-medical person, will understand this patient has oculocutaneous albinism. But there's so much variable expressivity. Some patients come in with oculocutaneous albinism and their skin isn't that lightly pigmented. Now, if you compare this girl to her siblings, there's a big difference in the skin pigmentation. But when you can have very mild defect. You can have almost normal skin pigmentation and more effect in the eye with the foveal hypoplasia causing oculocutaneous albinism. So just because a person isn't overtly looking like an albino, that doesn't mean they don't have oculocutaneous albinism. Looking for iris transillumination defects is very, very powerful in diagnosing these patients. There's a whole range of iris transillumination defect. There's a lot of variable expressivity. No one is going to miss the obvious case, but sometimes you really have to get the room dark, get that slit beam there to see those subtle transillumination defects. It can really guide you to the diagnosis of oculocutaneous albinism, and it can avoid a lot of unnecessary neuroimaging in patients who come in, children who come in with nystagmus or low vision, where there's not a clear etiology. Iris transillumination defects, something to look for in these children. Now, the last sign I'd like to share with you is exemplified by this patient, and it's actually an adult because I don't have a good video in a child, but let's play this video and see what this iris sign is. What do we see in this iris? This, of course, is iridodenesis. Iridodenesis, which is a sign of zonular weakness. And sometimes children come in and have iridodenesis, and it's a sign of zonular weakness, and it's actually a sign of the most common cause of zonular weakness in children, that is to say, fibrillin mutation, which is a predisposition for Marfan syndrome. This woman actually came in for a routine exam, wasn't complaining of vision, because her sister was diagnosed with Marfan syndrome. And we saw this horrible iridodenesis. She actually had dilatation of the aortic root, and she required emergency surgery. Unbelievable, she made it to this age, and she had not been diagnosed with Marfan syndrome, but she had progressive dilatation and required aortic surgery, which actually probably saved her life, because she came in for an eye exam worried that she might have the same condition as her sister. We see a lot of children with myopia these days, and it's not a surprise to see a child with myopia, but we have to really try to look at the iris, particularly if it's high myopia or if there's astigmatism or the refraction is fluctuating. This girl came in, and at the slit lamp, she has iridodenesis. There's no frank ectopia lentis, but the zonulars are weak. Any child who comes in with iridodenesis or frank ectopia lentis, you really have to look out for fibrillin mutation, more specifically, the cardiac manifestations of Marfan syndrome. And this girl actually had genetic testing, and it was negative for fibrillin mutation. But that doesn't mean anything. You know, it means something, but it doesn't mean that the suspicion is still not there, because genetic testing is not perfect. Clinical suspicion wins over genetic testing. And we insisted that this family go for cardiac evaluation, even though fibrillin mutation testing was normal. Actually, I didn't order that testing. It was done by someone else. And sure enough, when she went for cardiac evaluation, there was dilatation of the aortic root. It was progressive over time. She's followed and managed by pediatric cardiology. This can be managed medically. This is life-saving for these children. We have a bit of a burden on ourselves to identify these patients. Nobody's going to have as high suspicion for this condition as us if a child comes in with iridodenesis. Doesn't matter what the genetic testing shows. Genetic testing is imperfect. It doesn't always pick up mutations. This family was falsely reassured because someone else told them they didn't have Marfan syndrome based on the genetic testing, but that's wrong. Genetic testing doesn't rule out diagnoses. It only rules in diagnoses. Genetic testing is imperfect. Sometimes it doesn't find the mutation, but the clinical exam can really point very strongly that a patient has a condition. The zonules, of course, are composed of fibrillin. It's not a surprise that you can get iridodenesis when there's fibrillin mutation. Fibrillin mutation can be a marker of risk for progressive aortic root dilatation. These patients need to be evaluated by a pediatric cardiologist. It can be life-saving in children. Nobody's going to miss a patient with obvious Marfan syndrome. Again, a layperson will recognize the habitus of obvious Marfan syndrome, but sometimes children come in and they only have the iridodenesis or the ectopia lentis without the body habitus, we have a burden on ourselves to detect these patients early, because if we don't do that, it can really increase the morbidity and even mortality of these children who have fibrillin mutation. So the third iris sign not to miss is iridodenesis. Thank you so much for having me as part of this webinar. I will stop there because of time constraints. Thank you so much. Let me stop sharing.
Very much. Thank you very much, Dr. Khan. That was a wonderful lecture. And thank you for giving us those insights of a very careful slit lamp examination and not to miss looking at the details of the iris. So these were great cases and amazing insight. And as you said, it can not only save eyes, especially with the neurofibromatosis, but also save life with the other signs that you spoke of, that is iridodenesis and identifying Marfan's and ectopia lentis. So that was really insightful. So thank you very much for that. So I actually just had a quick question. So with regards to albinism, I mean, I know that this would be like one of the major criteria, like iris transillumination. Am I right to be able to fulfill clinical criteria for albinism? And, in addition to the nystagmus, low vision, and foveal hypoplasia in a child who may not be so obviously blonde or having a blonde fundus. So,
yeah, there's something, you're bringing up a very interesting point. The geneticists have criteria for things like you diagnose Marfan syndrome if you have XYZ. You diagnose neurofibromatosis if you have XYZ. You diagnose oculocutaneous albinism if you have XYZ. But actually, we as ophthalmologists are actually better than those criteria in some instances. For example, if I have a child who comes in with iridodenesis, the iris looks kind of hypoplastic. The cornea is very flat. I am almost certain this patient has fibrillin mutation. I don't care about the other criteria. And because those criteria don't incorporate careful ocular phenotyping. If I have a patient who has iris transillumination defect and foveal hypoplasia, and it's a girl, I'm almost certain the patient has oculocutaneous albinism, even if it doesn't meet those other criteria. Now, of course, there are other conditions that share overlapping things, but when you take everything together in the ocular exam and you have a context, we can be better at diagnosing these conditions than the general geneticists.
Yep.
For neurofibromatosis, if I have a patient with leash nodules and I have these hypermelanic spots on the near infrared imaging, I know that the patient has neurofibromatosis. I don't care if they have cafe au lait spot or not. Right? So this is the power of the ocular phenotyping, and not the general geneticists are not as attuned to it. So I hope that's answering your question. Sometimes we're better than the geneticists in some of these conditions in making the diagnosis, because the general geneticists, understandably, are not so hyper-focused on the nuances of the ocular exam.
Right. Yeah.
And we know certain combinations in certain contexts can only be one thing,
Yes.
or almost or certainly one thing, whereas they're not, they have the criteria in the different parts of the body. So I hope that answers the question. If you really have a good, understanding and background, it can be, I've had situations where I've argued with the geneticist. They say it doesn't meet the criteria, and then we go and do the genetic testing, and of course it's positive because just the familiarity with the ocular phenotype.
Right.
So there are several conditions like that where the ocular phenotype is just pathognomonic.
Yeah. Thank you. Thank you so much. Any other questions, or we could maybe move on to the next? So, since a little bit of this was discussed in your lecture, we'll move on to a bit more about lens abnormalities, and I request Abhinaya to please share her screen.
Sure. So is my screen visible?
Yes.
Yeah. Uh, Good evening, everyone. Thank you so much for this opportunity. So I'm going to present a 1-year-old female who presented to us with her parents with chief complaints of the child not able to focus when light is thrown at her very far distance, and she was only able to see when objects are brought closer to her. So there was no previous history of any associated ocular symptoms or any squint or history of any abnormal head posturing or history of any refractive error checkup elsewhere. Coming to the birth history, she was born out of non-consanguinity and through an IVF pregnancy, and the mother gives history of previous failed pregnancies and ectopic pregnancy. She was born at 37 weeks, and she had a 5-day NICU stay for transient achypnea of newborn and hyperbilirubinemia. Her milestones and her developmental history was appropriate for her age. Her father had myopia. Apart from that, past ocular and medical history was insignificant. On external examination, she appeared to be taller than her peers, and a redundant periumbilical skin was noted. Coming to the ocular examination at the first presentation, she had a high myopic refractive error of around -24 diopters per in the right eye and -23.5 diopters per in the left eye with normal intraocular pressures. And the anterior segment revealed megalocornea in both the eyes with small lens which edge can be made out in the fully dilated pupil, suggestive of a microspherophakia. The posterior segment had 0.5 cup disc ratio with good healthy rims, and the retina was on. So our plan was to put her through complete systemic evaluation, an echo, ultrasound, abdomen, pelvis, a routine blood and urine examination, along with whole exome sequencing. And she was planned for examination under anesthesia from glaucoma and pediatric ophthalmic point of view for comprehensive eye evaluation and further management. However, the patient got lost to follow-up since the parents had to leave for personal emergencies outside India, and they told that they would follow up in their country. But they came back to us 1 year later, where she had undergone examination under anesthesia at Ireland, and genetic testing was done there, and she was prescribed glasses, but she was not on any ocular medications. So this time we did take her up for an examination under anesthesia, and these were the findings which was noted. The myopic shift was much more than the last visit, and the intraocular pressures this time was normal in the right eye, but was high in the left eye, up to 38 millimeter of mercury in Perkins tonometry, and the axial length was 24.96 mm in the right eye and 27.9 in the left eye, with megalocornea in both eyes. And the gonioscopy showed open angles in the right eye with closed angles in peripheral anterior synechiae up to 5 cloacas in the left eye. So the anterior segment photography of the right eye under examination anesthesia is depicted, which shows microspherophakia, megalocornea, and subluxated lens anteriorly. And in the left eye showed microspherophakia, megalocornea, central corneal opacity where the site of lenticular corneal touch and iridocorneal touch with shallow AC and subluxated lens. So the posterior segment should 0.4 cup disc ratio in the right eye with 0.8 cup disc ratio in the left eye and bipolar notch. So with this clinical presentation, we made the diagnosis of both eyes microspherophakia, megalocornea, ectopia lentis with left eye secondary angle closure glaucoma, and the genetic testing of the proband revealed exon 4 homozygous autosomal recessive inheritance mutation of the LTBP2 protein. So the management, since she had a secondary angle closure glaucoma, we went ahead with the left eye lensectomy and goniotomy. This is a quick video which shows the MVR site entry and the viscosynecholysis, followed by iris repositor used to reposition the iris. And the Catena gonio lens was used to perform a goniotomy in the nasal and the temporal angles. Due to time constraints, I'm passing the video quickly, finishing up with a lensectomy and limited anterior vitrectomy. So 2 weeks later, the right eye goniotomy and lensectomy was performed. And this was the ultra-wide field fundus photo of the child after post-op. So the right eye had a cup disc ratio of 0.4 and the left eye 0.8. So the postoperative course was as follows. The right eye maintained her intraocular pressure over the period of 4 to 5 weeks. At the end of 6 weeks, she maintained a visual acuity of 6/12 with phakic rehabilitation. When it comes to the left eye, she had a stormy postoperative recovery period where she had persistent elevated high pressures despite maximum anti-glaucoma treatment. And at the end of 5 weeks, we decided to go ahead and implant an Ahmed glaucoma valve with tube entry and sulcus. And bitaxolol was given twice a day for the hypertensive phase. After 1 week of AGV implantation, her pressures are maintained at 10 millimeters of mercury. So coming to a small discussion about ectopia lentis, the most common genetic association is fibrillin genes, whereas the non-fibrillin genetic association includes the various other genes depicted, whereas the most important point to note here is that Weil-Marchesani syndrome and macrospirophagia, because of the gene involvement of ADAMTS10, ADAMTS17, and LTBP2, can have very similar presentations, but we have to make sure to differentiate them in terms of other systemic factors that can take a major role in cases of Weil-Marchesani syndrome, like short stature, brachydactyly, joint stiffness. And whereas when the LTBP2 is concerned, the mutation can just cause an isolated microspirophagia or a Weil-Marchesani-like syndrome. So the latent transforming growth factor binding protein is important for the extracellular matrix component, and the fibrillin 1 and the LTBP2 encode two major components of the zonule, and it's important for the tensile strength. So when the tension in the lens is not maintained, they tend to take the microspirophagia phenotype. So LTBP2 mutation can present in various formats: megalocornea spirophagia, ectopia lentis with or without secondary glaucoma, isolated microspirophagia, Marfan-like phenotype, Weil-Marchesani-like phenotype, and congenital glaucoma mostly associated with microspirophagia. So the features of LTBP2 related ocular dysgenesis has been published in a cohort, in the Indian cohort done by L.V. Prasad. And one key features to be noticed in this cohort is that when it comes to the retinal pathology, it needs a meticulous workup and also to rule out other associations like peripheral chorioretinal alterations, lattice degenerations. And in their cohort, they also found suprachoroidal hemorrhage and RD in post-lensectomy eyes in such LTBP2 mutation affected children. And one other interesting point to note is that in this discussion, we had also mentioned that recurrent exon mutation in this particular exon 4 variation has been seen in two unrelated families. And this could have potentially be a hotspot for the LTBP2 variants, which was similar to the variant that we found in this particular child who presented to us. Apart from this, a Chinese study also published that biallelic homozygous frameshift mutation may be associated with a more severe ocular phenotype, and retinal damage should be noticed in these patients. To conclude, megalocornea without HAPS dry lens abnormalities, ectopia lentis, microspirophagia in a child is not always PCG, and it's crucial to diagnose and differentiate because the primary line of management changes where we have to decide between a lensectomy versus an angle surgery. Systemic workup and whole exome sequencing is crucial. Retinal evaluation and prophylactic treatment, lasers wherever required has to be considered, and visual rehabilitation is of an essential use. I'd like to acknowledge the Pediatric Ophthalmology and Glaucoma Department of Shankar Nethralaya, and thank you for this opportunity.
Great. Thank you, Abhinaya. So thank you for going through this wonderful case and all the details. I just wanted to, with regards to our time constraint, just wanted to say that it's like the child you saw was like 1 year old. So it's very difficult to try and, evaluate whether this child has short stature or short stubby fingers and, put in a syndromic association from just by looking at certain things, but definitely the high myopia and a high myopia which is not correlating with an axial length. Like that itself is a clue that there is another reason for the myopia. It is not axial, and then we need to look at the lenticular component, which is in most cases an ectopia lentis. And then once we have established that we are dealing with a case of ectopia lentis, then try and figuring out whether it is something in isolation or is there any systemic associations, is there a syndrome associated. So I think it's very important, as Dr. Arif Khan always mentions, the phenotype is always very important, and doing a deep phenotyping is crucial in all such cases of ectopia lentis. So this was a well-managed case. I'll pass on the baton to Dr. Arif Khan for his comments.
Yes, thank you. I'll make two comments regarding the time. I think the big clue in this case was the megalocornea,
Yes.
right? The megalocornea, that immediately is pointing towards LTBB2 mutations. LTBB2 was originally described as the second primary congenital glaucoma gene in like 2009 or something like that. There was a group of patients who were diagnosed as primary congenital glaucoma who were negative for CYP1B1 mutations. And it was some Pakistani, Gypsy, and Iranian patients, and they ended up being positive for LTBB2 mutations. And for that reason, it was described as a primary congenital glaucoma gene. But going back to what we were talking about in the very beginning, those patients should have never been labeled as primary congenital glaucoma, because actually they were phenotyped as adults and they all had ectopia lentis and they had corneal scarring and they had end-stage phenotypes. Actually, what they really had was this primary megalocornea with ectopia lentis and a secondary lens-related glaucoma. So the poor phenotyping or the non-specific phenotype inappropriately labeled LTBB2 as a primary congenital glaucoma gene, where it really isn't. It really causes this condition primarily. Now, the one other thing I want to say about this condition, in my experience with this condition, is if you get the lenses out early, they don't get glaucoma in general. And the patients who get glaucoma are the ones who are left like the one you had, and the lens bounces around and causes sneaky eye, and then they get glaucoma, or they have inappropriate surgeries for primary congenital glaucoma, and they get scarring, then they get a glaucoma that persists even if the lens comes out. But at least in my experience, for the patients that I've encountered, if it's recognized early and the lens comes out early, they tend not to get glaucoma. So it's important to recognize, to manage them appropriately. If they're left for a long time, they get a glaucoma that persists even if the lens comes out. That's
Yes.
what I'll say.
That's right. Yes, you treat the inciting cause, and then the secondary complications would thereby be avoided in most cases. And also, generally in cases of ectopia lentis, doing a routine urine examination looking for homocysteine in urine is also hypohomocystinuria is also very important. It's a simple test, so that would be like after a clinical examination, doing blood investigations.
It's true. It's true. I'll make one other point though.
Yes.
The patients with homocystinuria tend to present at 6 the earliest, 7, not before 6.
Yes.
These patients, LTBB2, they come in 2 years old, 1 year old. So the age of presentation also. I mean, Marfan, you can have some rare Marfan ones that come very early, but in general, Marfan and homocystinuria, 6, 7. LTBB2 can be any age, and it can be 6 months old, they can be 1 year old. So immediately when you see that, especially if the cornea is big, it should point you in that direction.
Yeah, true. Thank you so much. Thank you, Dr. Arif Khan. And let's move on to the next case, which is by Dr. Deepika. So I request Deepika to please share her screen.
Okay, I hope my screen is visible and I'm audible, Dr. Manju.
Yes, Deepika.
Yes. Okay.
Please go ahead.
Yeah. Thank you. A very good evening, everyone. Thank you, team AIOSSC Scientific Committee, Dr. Manju Bhatia and Dr. Somshila for this opportunity. I'll be presenting a case of a child with titled as Night Scares and Eyes Wonder. Straight to the case. This is a 12-year-old female child with age at first symptom onset around 3 to 4 years of age, where the parents had noted difficulty in dim light vision as well as in the night. The child also had central vision problems, photosensitivity, and shaking of eyeballs very early in the age, started around school age. Both peripheral vision and central vision were affected. The right eye vision was 6/60 at presentation to us with an 18 near vision. Left eye 6/24 with a myopia of minus 5.5 diopter spherical equivalent. and in 12. The general health was fine. The past history showed that the child had squint surgery for alternating exotropia, and the vision in 2022 was right eye 624, left eye 618. So we can see that there is gradual progression in the vision loss. This is the 5th-generation pedigree and the affected proband, 12-year-old female child born out of a consanguineous marriage. And mother of both the proband's parents were cousins. There was also one family member on the paternal side who was blind at adult age group, though we have not examined this person. In the clinical presentation, the color fundus optos white field images of both eyes, what we can see here is there is prominent attenuated vasculature, arteries more than veins. There's diffuse RPE degeneration seen as yellowish pigmentary changes in both the retina. There's also very minute black bony spicule-like pigmentary changes on the temporal side of the retina in both the eyes. There is macular atrophy and pigmentary changes more evident in the right eye. The fundus autofluorescence white field images shows that there is hypoautofluorescent these patches along the vascular arcades and in the mid periphery. The central macula has hypoautofluorescence with an adjacent small area of better or preserved autofluorescence in both the eyes. It is symmetrical, though the right eye atrophy is the macular atrophy is slightly in larger size. Optical coherence tomography of the central macula, both the vitreomacular interface and the inner retina is unremarkable. But what we notice in the abnormal outer retinal layers, ranging from outer plexiform, outer nuclear, ellipsoid zone, and even RP is lost over here, retinal pigment epithelium, where there is gross thinning and loss of layers in both the eyes. There are some hyperreflective residues or deposits at EZ level in both eyes. This is the fulfilled electroretinogram where the waveforms of right were marked in red and left is in blue. And when compared to the reference dark adapted or scotopic responses, we can see that the child has severely reduced or undetectable responses. The photopics too, when compared to the reference, has severely reduced or undetectable responses. What it says is there is a severe generalized rod cone dysfunction in retina of both the eyes. To summarize the clinical phenotype, we have a young female child who has presented with both involvement of rod as well as cone system, nyctalopia, nystagmus, photophobia, reduced vision, which are early onset, less than 5 years of age, and the retinal imaging shows pan-retinal changes involving the macula. The electrophysiology shows generalized rod cone dysfunction. The clinical phenotype, due to the presenting symptom of first being nyctalopia, or the parents how they reported it, it belongs to the rod cone dystrophy, and which we call it as retinitis pigmentosa here with macular involvement, which belongs to the spectrum of retinal dystrophy called early onset severe retinal dystrophy. When we see kids at this age, it could also be cone rod dystrophy, just that when we see at the advanced stages, sometimes it is very difficult to differentiate whether it is rod cone or cone rod unless we have a good presenting history and the flow of how the symptoms started. So this child underwent exome sequencing, and what we noted here was homozygous missense variant in exon 18 of PROM1 gene. PROM1 gene variants, the pathogenic variants, are known to cause autosomal recessive retinitis pigmentosa. However, in our case, the reported variant is uncertain because of the conflicting evidences. There was one more genetic finding that is heterozygous termination variant in exon 9 of SPATA7 gene. SPATA7 pathogenic variants are known to cause autosomal recessive retinitis pigmentosa, and the found variant here is termination, and it is likely pathogenic. So a bit on PROM1 retinal phenotype, major points only. So the PROM1 retinal dystrophy can present with these kind of phenotypes, that is cone rod dystrophy, rod cone dystrophy with macular involvement, macular dystrophy, or a late onset Stargardt-like phenotype. The PROM1 can have both kinds of patterns of inheritance, that is autosomal recessive and autosomal dominant. And in general, when it is presenting in a childhood age group, it will be autosomal recessive, and they will have more severe dysfunction with respect to rod cone dystrophy or cone rod dystrophy. And the autosomal pattern or dominant pattern, mostly macular dystrophy, and on the later part of adulthood. So the presenting symptom can vary from onset childhood to late adulthood. This is the representative image which I put from the literature of autosomal recessive PROM1 IRDs. Both the patients had a childhood onset disease, and here this image is at 50, where we are seeing that the prominent macular atrophy is more prominent, and the pigmentary changes with involvement of macula is very clearly seen in the fundus. In the below image, this is taken at 20 years of age. So the age at which we image or we examine the patient becomes very important when we are trying to do a genotype-phenotype correlations. Dr. Khan has also published a very early case report about 10 years back. I think the PROM1 autosomal recessive cone rod dystrophies with high myopia and nystagmus. So the autosomal recessive are generally will have a severe onset retinal dystrophies. SPATA7 retinal phenotypes can have Leber congenital amaurosis or retinitis pigmentosa, which is mostly juvenile, and it is in autosomal recessive pattern. The most common and the most severe dysfunction is seen in Leber congenital amaurosis in SPATA7 retinal phenotype. These are few images where we see how the fundus can have vary from being normal to this prominent yellowish changes in the mid periphery. And this is the image of the same patients, both the eyes, from 3 years to 8 years, how these pigmentary changes evolve. Coming back to the genetic report, though here we have found homozygous variants in PROM1, and this could be PROM1 because our child is fitting into early onset retinal dystrophy phenotype, whether it is rod cone or cone rod, both can be caused by PROM1 pathogenic variants. However, this genotype requires further validation. The SPATA7, right now we are missing the other variant, or it need not be causing disease in our child because it is slightly less severe compared to her age for SPATA7 LCA. And the lab also reported when we asked further that there was no other relevant variants detected in coding region or exon intron boundaries of SPATA7. Going back to the specific variant which is found in our case, initially, like the specific serine 649 to leucine 1 report, the studies have reported that it could be non-pathogenic because they found this in homozygous fashion in some of the non-affected people as well. However, in the subsequent years, there are reports which have reported the pathogenicity of this specific mutation, which is seen in our child presenting as cone rod dystrophy. And this is a study on homozygosity mapping, where there were two families with the patients having same mutation. And interesting was that the affected patients also shared same haplotype, indicating a common ancestry in that. So this variant, which is found in our child, could be causing the phenotype. To summarize the take clinic message, when we have a child who presents with night scares and eyes wander, early onset retinal dystrophy is to be kept in mind. Fundus can be normal or paucipigmentary in these retinas. There is a spectrum of phenotype where LCA is at the severe end and followed by early onset severe retinal dystrophies, and then we call it as juvenile onset diseases. ERG in all the diseases shows severe dysfunction. Genetic evaluation and early low vision rehabilitation is mandatory. Another two differentials with respect to retinal dystrophy, which we need to keep, is if the child has nyctalopia and nystagmus, is congenital stationary night blindness. Nystagmus and photophobia, of course, not to miss the achromatopsia variety. In our child, just to complete the workup, the low vision rehabilitation was done with RO vision distant glasses. The child was able to read 6x6 and N6. Video magnifier will help with N6. Noir filter was also given because of the photosensitivity. Red and amber type helped our child. Parental segregation is advised. I'm not sure whether to consider SPATA7 at this moment and go for an entire gene sequencing to identify any intronic variants. I would request Dr. Khan or Dr. Parveen Sen to opine on this, on the phenotype and further genetic validation. Thank you very much, everyone. I acknowledge our GenEd team who helps with genetic counseling at Narayan Nethralaya.
Thank you very much, Deepika, for all the details and the detailed evaluation and including the vision rehabilitation, which I would say is really very important for the families. So I'll just pass the baton straight to Dr. Parveen and then Dr. Arif Khan for your comments, please.
Yeah, I think thank you, Deepika, for a very nice case. And I think it highlights the importance of thoroughly working up these children and keeping in mind the near normal looking fundus, even in patients who have severe cone rod dystrophies. So this could be, we are attuned to see typical bony spicules and all that in retinitis pigmentosa, or even in very early cases in children, you may not have the typical triad of RP. So we need to recognize many genetic variants which can come with this paucipigmentary kind of presentation. And number two, it is vital to get genetic testing done in patients who come with cone rod dystrophy, especially in the pediatric age group, because more important than the visual rehabilitation, it is also important to understand that a lot of time these things can be syndromic. So your genetic analysis has at least shown up that we don't have a variant which could be associated with a renal problem like a senior loken, or it could be associated with the heart issues or a hepatic fibrosis. So those things are also equally important. Coming to the genetic test per se, I think what you did was a clinical exome, right? And it was um,
Yes.
I would still say the number of cases of PROM1 that I have seen, this picture doesn't typically fit into a PROM1. I usually, even the autosomal recessive PROM1 causing RP sometimes has those discrete areas of macular atrophy, as well as in the periphery, you get those discrete areas of chorioretinal atrophy. So there is a possibility that the SPATA 7 may still be influencing this presentation, or if I'm not mistaken, there are deep intronic variants of SPATA 7 also described, which can be pathogenic. So I will not probably stop my genetic testing here. I would definitely want some more testing to be done, whether it is in form of a whole genome or it is testing of the parents as well, which could throw some information as to which of the two is the more significant one, because the PROM1 variants which were picked up were of moderate severity, and to give such a severe phenotype so early in the age group, I would still keep SPATA in mind. Look forward to Dr. Arif's comments as well.
Yeah, thank you for this presentation. It highlights that just because the program predicts something as pathogenic or likely pathogenic, you really have to correlate with it with the clinical features, and you can't just go by the report. Everything has to fit together. I think I don't remember how many siblings this patient had, but I think the best way to start would be to look at the siblings, because if you find one of them is homozygous for that variant, then the chance that that variant is causative goes way, way down. So I find it useful to look at siblings, and it's not that expensive to look for the specific variant. When you're looking for a specific variant, as opposed to broad testing, it's actually quite cheap. And some labs even allow you to do it for free if you're trying to confirm a finding that they had, because it's in their interest also to know whether or not that's pathogenic or not. They want it for their database. So sometimes they offer free targeted sibling analysis to try to confirm or deny a variant as pathogenic. So that's the way I would go. I have to say also is that, there are classic phenotypes that we associate with genes, but more and more we find surprises where mild variants in a particular gene sometimes cause a phenotype we don't expect. And so we're still learning about this, and it's not impossible that it's related. It just takes more evidence. It's like you're trying to convict someone of a crime. Just because somebody was there, that doesn't mean they're guilty. You have to all have all of the supporting evidence before you can put him in jail. So you have to get the evidence until it's enough that a court would agree that this person has to go to jail. The other thing I'll say that you brought up, it's kind of a side point and it's interesting. You mentioned for this variant that in one population or some populations, it was thought to be not disease causing, but then there was some other papers that thought it to be disease causing. This is a very important point because there are some variants that are pathogenic in certain populations, but not in others. And this has to do, again, with the fact that these variants do not work in isolation, or they don't cause problems in isolation. You're looking at variants in one particular gene, but there are 20 or 30 thousand other genes in the genome that are in the background. And sometimes we have genes that are pathogenic in one population or one person and not in another person. So there are definitely other factors at play, and we have to keep in mind the ethnicity of the population we're dealing with when we look at these variants and we're interpreting the reports, because sometimes it's different for different populations. Thank you so much.
Thank you very much, Dr. Arif Khan and Dr. Parveen, for the great discussion. I just had a very basic question just for the wider audience. With regards to electrophysiology, I mean, Deepika's case was like a really severe onset early cone rod. But if it was maybe a retinal dystrophy, which probably would have been milder or something, how reliable would you consider ERG testing at what age? Like, is it 3 months, 4 months, 6 months? Sometimes we get patients who we think maybe they've got a delayed visual maturation, ruling out other causes. So when would the electrophysiology be the most reliable as the youngest age?
See, I think when you do electrophysiology in children who are anything less than a year old, the most important thing you are trying to look is it flat? That is the most important question that you are trying to answer. So as long as you get some recordings, you actually rule out LCA. So that is one of the most important information that you are looking at. The cone rod dystrophies, even the early onset ones, will still come at 1 year plus 2-3 years of age. And at that time, you can do a reliable ERG with skin electrodes without general anesthesia. Usually, electrophysiology done under general anesthesia, I would really find it very, very difficult to interpret. That will be less reliable as compared to electrophysiology done with skin electrodes in a child without anesthesia.
Okay. Thank you so much. Thank you for that wonderful tip. With this, we'll move on to the last case.
Thank you all.
Thank you, Deepika. So we'll move on to the last case, which is a mitochondrial mystery. And let's see if Janil and Swati can solve this mystery. So over to you, Janil.
Is my okay, am I audible and are my slides visible?
Yeah. Can you go to slideshow? Yeah, perfect. Thank you.
So at the outset, I would like to thank Dr. Manjushri and AIOS for this invitation for the webinar. And I must say, very interesting cases in the past 1.5 hours. So I'm going to cover about an interesting case which we came across with multiple diagnosis and a mystery till a simple genetic test solved and answered many questions. So I'll just jump onto the case directly. A 10-year-old boy presented to us with a diminished vision in either eyes for the past 2 months. It was painless. It was non-progressive as per the child and the parents who accompanied them. We went into a little bit detail about the medical history. It was gradual and painless blurring, which was first noted more in the left eye than in the right eye, and the left eye onset was few weeks prior as compared to the right eye, as the child had reported to the parents. And before consultation to us, the child had prior consultation for a blunt trauma to the left forehead, which was around 2 months ago, and for which a single dose of venous steroids was given, and the details were not very clear to us as the past records did not reveal anything particularly given. In the process, the child was also advised a CAT scan, a VEP, and a ERG, and then eventually was referred to a tertiary eye care center for the unexplained vision loss. When we looked at the EEG and the ERG and the VEP report, it appeared to be normal, and particularly mention of no optic pathway involvement. So at the examination and at our clinic, the child had a visual acuity of 20/80, best corrected to 20/60 in the right eye, and the left eye 20/600 with best corrected to 20/500 with a poor near vision in the left eye. In spite of the asymmetrical vision loss, here we note that there was no relative afferent pupillary defect, and the pupils were very sluggishly reacting in the left eye. The motor examination was essentially normal. There was no strabismus, and the sensory examination revealed a very poor stereo acuity of 400 seconds over. When we did the fundus examination, if we see very closely, the first cursory look, the fundus looks essentially normal with the normal optic nerve head, the vessels appear normal architecture, and the retina seems to be very healthy. But when we have a close look in the left eye, we see that there is some pallor, which when we compare to the right eye, that's definitely more temporally as compared to the fellow eye, the right eye. And this is the left eye, which has a poor vision as compared to the right eye. Also, the RNFL appears to be overall normal, but there is mild thickening of the RNFL in the peripapillary area, but it's not very specific. So we took further imaging methods to ascertain that what could be going on in the child who otherwise has a normal ocular examination. We repeated the VEP for this child when he presented to us, and we can see that in the right eye, even up to the 7-minute checkerboard size, the amplitudes keep on reducing, and there is a delayed in the latency. The P100 is 128 in the right eye, which is the relatively better eye, whereas in the left eye, the amplitudes are still okay in spite of the poor vision, definitely, but a remarkable delayed in the latency going up to P100, going up to 149 for the 30-minute pattern reversal checkerboard size. So delay in latency, yes, but the amplitudes are pretty okay if we grossly look at the VEP reports. So we then moved on to the perimetry, and the perimetry was very classical, typical, showing a central and a centrocecal scotoma in the right and the left eye typically. So this ideally explains in the left eye, which has poor vision, that the child is not able to use his peripheral vision, and which is very obvious. And the central vision scotoma, centrocecal scotoma, is contributing to the 2500 vision, whereas the relatively better eye, which is the right eye in this case, has not a very dense scotoma, but definitely some depressed points centrally, which is contributing to the 20/60 vision. To corroborate these findings, we also looked at the RNFL and the MGCL, and of course, we do not have a standardized data for children less than 18 years of age in the serous OCD, but we standardized the data by looking at other normative data of the children presented to us demographically in our clinical setting. But we definitely see some thinning which is there of the temporal RNFL in the left eye here compared to the right eye, might as well also corroborating to the nasal MGCL thinning in the left eye compared to the right eye. So definitely there are changes, though we do not have a standardized comparative findings. But all these corroborate that there is an MGCL thinning, there is a RNFL thinning, there is a left eye involvement in terms of near normal amplitudes or reduced amplitudes from remarkably delayed latency, and a center and a centrocecal scotoma in the left and the right eye respectively. So this summarized that the onset of vision loss is acute and subacute, possibly. It's quite variable because the child reports variable findings in multiple settings, and male child, of course, which is again important. Pupils are sluggishly reacting, but there is no afferent pupillary defect, suggests that there is an afferent pathway involvement, though asymmetrical vision loss, but there is definitely a bilateral involvement, and it is not a unilateral condition. Color vision is variable because the right eye color vision is still maintained as compared to the left eye. It does not have any significant refractive error, the rules of amblyopia, of course, and the investigational findings, which definitely corroborates to the vision loss, which is the classical centrocecal scotoma in the left eye, and the corroborative MGCL and the temporal RNFL thickening. With near normal VP, I would not say exactly, but definitely delayed latency in the left eye, and the ERG, which was done elsewhere, was reported normal. So there are a couple of provisional diagnoses which comes into our mind is a pediatric optic neuritis, though the onset of the vision loss is definitely very atypical. And we do know that pediatric optic neuritis have a painless vision loss. It's a bilateral usually involvement. It could be asymmetric. And of course, conversion disorder was something which was in mind initially, but then we see conversion disorders will not have a typical centrocecal scotoma, and such children would have near normal findings, but they would never report that the vision is good for the other reasons. So the question is, what next? And in this case, we felt that the MRI would be, neuroimaging would be a good tool to confirm our findings, what we are finding in the VEP as well as in the HVF. To our disappointment, there wasn't any significant finding we could see in the axial T2 weighted images. There were certain hyper intensities which are reported, but there was no significant thinning of the optic nerve. And the post contrast scan, which I have not put here across, did not reveal any remarkable contrast enhancement of the optic nerves throughout the pathway of the visual pathway. So does not corroborate exactly to a typical pediatric optic neuritis. The next thing we got it done in spite of these negative findings is get an aquaporin 4 antibody and the emoji antibody, which both were negative in this case, because seronegative cases of optic neuritis are very well reported, then constitute a significant proportion of pediatric optic neuritis. With this discussion with the parents, we still went ahead with intravenous methylprednisolone of 250 milligram twice a day, a total of 500 milligram for the next 5 days. Considering that with the VEP changes and the subtle MRI findings, possibly we are still likely that we should not be missing pediatric optic neuritis. And this was followed by an oral steroid slow tapering in the dose of 1 milligram per kg body weight. Now, over the period of 12 weeks, we can see that the right eye vision nearly continued to remain the same. And the left eye vision, however, which started with 2500 as a best corrected visual acuity, kept on gradually improving, but no significant improvement how a typical seronegative pediatric optic neuritis should have behaved. But we definitely see an improvement in the color vision, pupil responses got better, and the visual acuity partially improved in the left eye, but the right eye remained status quo. So these are the visual field progression over the period of time. The centrocecal scotoma continues to remain the same. However, the density keeps on getting better and better, and the scotoma size also reduces in the left eye and the right eye, which is corroborating with the improvement in the visual acuity respectively. Now the question is whether was it really a pediatric optic neuritis? There are a lot of findings which are against it, and is there something which we are missing? So let's go to the pediatric optic neuritis. Asymmetric involvement, yes. No MRI changes is not possible. There is usually a classical, either a long segment post contrast enhancement of the optic nerve or the posterior enhancement of the chiasm and the optic nerve, which were in our case was definitely not visible even in a well done MRI and well reported MRI. VEP definitely did not show any delayed in the latency in the right eye, but left eye definitely revealed a prolonged latency, but the amplitudes did not corroborate with the vision loss which the child reported. Could it be a primary optic neuropathy? Is there something which we are missing and should start looking at a alternate diagnosis? Central scotoma, yes, this child had a central and centrocecal scotoma. The onset was very insidious, subacute onset, painless vision loss, and no afferent pupillary defect in spite of this asymmetrical vision loss, which is very unusual for pediatric optic neuritis. So what alternative diagnosis can we think of? One case is of hereditary optic neuropathy or a mitochondrial or autosomal dominant, which is Leber's hereditary optic neuropathy, are the other alternatives what came into our mind. So we went ahead with the pedigree charting and looking at the 3-generational pedigree chart. We did not find anyone in the maternal or paternal side which were affected with similar symptoms or signs. We also examined the parents, a very superficial examination of pupillary examination, visual acuity, color vision, as well as looking at the optic nerve head. So either of the parents did not have any abnormalities, had normal visual acuity with a healthy looking optic nerve head with a normal color vision testing. So with this still, we went ahead with a genetic testing to look at the first common possible etiology, what we can think of, though the child is only 10 years old, to look at three common point mutations in the mitochondria, which signifies, which is a spectrum of the Leber's hereditary optic neuropathy. And to our surprise, though we have seen a lot of number of patients in a young middle age in 20s, this turned out to be positive for the one of the common point mutation, which is 11778 mutation. And this was the likely case in this patient. And the child was referred for genetic counseling to understand further about their family history, and also if there is any other male members, though we had done the pedigree charting. So this was a little surprising to us, only in terms of the presentation, but also in terms of the age of the child, because this was probably the first presentation of such a young patient who otherwise was diagnosed as optic neuritis. But then when we thought more about it and we looked at it is not fitting into the picture, then we pushed on to genetic workup, and we could see that positive for LHON. So both eyes, Leber's hereditary optic neuropathy, and now it was time to discuss the treatment options. It was already roughly around 6 months after which we diagnosed when they presented to a clinic, and the child already suffered from 3 months of vision loss. So from the onset of the disease, it was nearly 9 months when we diagnosed the child with optic neuropathy due to LHON. So we discussed the management options with the patient. The child was 40 kgs, 10-year-old, and the onset of vision loss is probably roughly around 9 months. So we discussed about the options of Idebenone, also about gene therapy to the parents, and the family decided to go against Idebenone for one reason being that the dose is from 450 to 900 milligrams, and the child, since only 45 milligram tablets are available in India, the child has to take 10 to 20 tablets a day for 1 year, with the visual recovery, which is very variable, as we know from the recent studies. So the child continued on multivitamins and folate supplements. We also advised POCU supplements, when again it was turned down by the parents, and they continued to be on just on multivitamins. So I would like to discuss more with the panel discussion and about the role of Idebenone in late diagnosis of LHON, and also in pediatric cases, and the role of gene therapy in such cases. And I would like to invite comments and suggestions from the other panels. Thank you.
Thank you, Janil, for going through all the details of a detective-like analysis to reach your diagnosis. I'll first start with Dr. Swati Fulgile and then invite Dr. Arif Khan for comments, please.
Thank you, Manju, and thank you, AIS, for this opportunity. Janil, it was indeed a great case. And as you rightly said, that there were many points against an atypical optic neuritis in pediatric group, because generally what we expect in a pediatric group, one, there has to be kind of bilateral involvement, which of course was there, even though it was not simultaneous, it was sequential. But what is surprising is lack of disc edema. Right? Generally, in pediatric patient, disc edema is much more common presentation as compared to retrobulbar neuritis, and your OCT picture also, kind of clarified it, because even if there is a retrobulbar neuritis, there has to be some evidence of RNFL thickening, which was not so significant on OCT. Then, of course, if you go by pupil reactions in optic neuritis, the amount of RAPD is much more significant as compared to disc findings, or even compared to a vision loss. The amount of RAPD is much more significant, which again was not probably the case. So I think these were the pointers probably to make us understand that we are kind of looking at a different diagnosis than an atypical optic neuritis, and particularly MRI also, as you showed no evidence of any enhancement except for those mild subtle hyperintensities on T2s, which even though have been reported in LHON also. It's not that they are not at all reported. They have been kind of in acute stages have been reported. So I would say probably from the beginning itself, the case gave us an idea that probably we are not dealing with a case of optic neuritis, whether typical and atypical. So indeed, as you rightly did, that you did a genetic analysis, and it turned out to be positive for one of the primary mutation, where you are say lucky, because not everybody where we suspect a clinical suspicion of LHON will have mutation positive. So it's in India, as from various studies we have seen, only 30% of cases where we suspect LHON as a clinical diagnosis may not have a positive mutation. So a clinical diagnosis becomes, or a clinical presentation becomes, very, very important there. And as far as treatment is concerned, Idebenone, we all know, is not so easily accessible, particularly at that high dose in India. And then we are left with not many options except to give a cocktail therapy of multivitamins and probably antioxidants. What we can do is to ask for, preventable risk factors that can be avoided in these patients. That's it. Dr. Arif, comments from you will be most welcome. As far as treatment is concerned, Idebenone and recent gene therapy, what is your take on it?
Yeah, thank you for this very interesting case. I'll just start by saying that gene therapy is not available. I mean, there were trials, but there's nothing commercially available. And idebenone is controversial. It's not FDA approved in the United States, but people are using it. I don't really have experience because it's not approved. We do inform patients about it if they want to use it on their own, but I don't prescribe it. But I'd like to make a couple of points about this case. I recently saw my youngest patient with LHON. He was actually 8 years old, and he didn't present acutely. He presented with reduced vision in school one day, and he had optic neuropathy. And this is the thing about the children. I don't think they present when it acutely happens. It's happening sequentially. When it happens in one eye, they don't say anything. That eye might get a little bit better than it happens in the other eye. So by the time they come to us, I don't think it's the acute stage anymore. And this is probably what happened in your case, why you didn't see anything active happening. The other point I'd like to make is that I have no doubt about the diagnosis here, and we certainly can make the diagnosis when a patient comes in with optic neuropathy and we find the mutation. But we have to remember that the carrier state for the mutation is much high. It's much higher than the number of people who have the disease. For the European population, it's estimated that something like 1 out of 1,000 carries one of the three common LHON mutations. But in that same population, it's something like 1 out of 40 or 1 out of 50,000 get the disease. So the vast majority of people who have these LHON variants that are known to cause the disease never get LHON. So we have to be careful about this, and it's becoming more and more of a problem with broad genetic testing. I have patients who have retinal dystrophy, and they go out and they get whole genome and whole mitochondrial testing somewhere, and they come in and they have one of the LHON variants, and somebody diagnoses them as LHON based on that. But phenotype doesn't match at all. So we have to be careful because there are more people who have the mutation than have the disease out there. The other thing I wanted to say about this, let me see, I wrote it down. Oh yeah, it's important, as you did, to do both the nerve fiber layer analysis and the ganglion cell layer analysis, because sometimes in these patients, when they're presenting, you do the nerve fiber layer analysis and it's normal, but it could be that there's edema there and it's thin, and that's why it's normal. But when you do the ganglion cell layer analysis, you see that it's thin. So it's important to do both of those, not just the nerve fiber layer, because sometimes it's normal, but it's actually edema over a thinned nerve fiber layer. So I was very happy to see you do that. So this is a very interesting case. There are pediatric patients out there. I've seen them myself, but it's important to understand that most people who have this mutation do not get the disease.
Thank you. Thank you, Dr. Khan. And agreed, as you said, when we do whole exome sequencing, we do land up knowing some more mutations, and that kind of can be a bit scary to the families as well. I just wanted to add a little point in this LHON. So we did publish a series in JPOS that was a couple of years ago, and we did have children in the first decade and second decade of life as well. So our range was from 9 to almost the outer one was 45 years. And these children who are younger, as in the first and second decade of life, or the teenagers, tend to do better with idebenone than the older ones. Of course, it is very variable, and we don't know who will and who will not respond. Somehow the juvenile onset ones tend to do better with regards to improvement in the vision with idebenone. Again, this is not a blanket statement, and not everybody will. But I'm forgetting the study, but I'm quoting it from one of the studies because I'd done a lot of literature search while publishing this particular paper. So yes, idebenone does have a role in those, and we do offer it in India because it is available, although expensive, and although we have to take sort of advise 20 tablets. But the important thing which Dr. Khan mentioned was that not all of them will present with LHON if they come positive in a genetic test. And the other thing which Swati mentioned was the preventative measure, that is avoiding oxidative stress. Of course, this is a young child, but all the smoking, drinking part, which we need to explain as well. So thank you very much for this wonderful case. Any other comment, or we can wrap up? Okay, so I think we'll wrap up this webinar. I thank everyone for their participation and sharing these wonderful cases. I really thank Dr. Arif Khan for all your wonderful inputs for all the cases and your great lecture that you gave us and making us more aware of iris signs, which I'm sure from tomorrow I'll be like a little more careful on when I put the child on slit lamp.
Yeah, indeed, that was wonderful and an eye-opening that we need to be more careful whenever we are doing a clinical examination.
Right. So thank you, everybody. And as Somshila mentioned at the outset, that this will be available on YouTube and Facebook and all other platforms. So for people to view later on as well. So thank you for your participation and wish you all a good night.
Thank you.
Thank you. It was a
Thank
great
you,
session.
everyone.
Thank you so much for including me. Thank you.
Thank you so much. Bye-bye.
Thank you,
Bye.
everyone. A
Bye.
great session. Enjoyed all the cases. Thank you.
Thank you so much. Bye.
Thank you so much.